Hello, this is a white blood cell disease hematology tutorial, part 2, presented by the SchrDbb, reference Follocular Lymphoma by Harald Thelm. So we're going to visualize here the predominance of the pathologies involving predominance of monomolecular round to oval cells, still called granulocyte. So now, this is a diagram visualizing all the different clinical findings that you're going to have in this disorder, but that is not going to be very important. If you want to know it, go on tutorials of internal medicine. So the first disease that we're going to start with is going to be reactive lymphocytosis, basically. So here in reactive lymphocytosis, we have morphologically normal lymphocytes which predominate in the blood analysis. Is it clear? So in this case, in reactive lymphocytosis, what is actually reactive lymphocytosis? Actually, yeah, you just have an acute infection resulting to an increased number of lymphocytes. As easy as that. So reactive lymphocytosis is not it's not an actual pathology, but it's a reaction to an acute disease. Is it clear? So that's what it's called, reactive lymphocytosis. Now you need to know that what. To know the disease that causes lymphocytosis, you have to know the disease that causes lymphocytosis, you have to know the type of pathogen that causes first increased number of lymphocytes. Now, the increased number of lymphocytes are increased because of generally viral infection, and you also have chronic bacterial infections. Is it clear? So these are now examples of diseases that you are going to see with that. The first disease that you have reactive lymphocytosis, you have whooping cough, also called pertussis. The second, you have chickenpox, measles, brucellosis. Chickenpox and measles are viral infection. Brucellosis is a chronic bacterial infection with brucella, causing a chronic granulomatous granuloma formation, which can be cassating, just like tuberculosis, or non-cassating. So the next one is hyperthyroidism and Addison disease. So hyperthyroidism and Addison disease are also going to cause type 4 are involved in type 4 hypersensitivity reactions. These are forms of type 4 hypersensitivity reactions, and this type 4 hypersensitivity reaction is involved still with the lymphocytes. So that's why you have reactive lymphocytosis. The next one, you have constitutional relative lymphocytosis. And is it clear? So it's just because of your body that you have a relative increase in lymphocytosis. You have absolute granulocytopenia can also be seen in lymphocytosis. If you have the decreased number of granulocytes, you may have a reactive lymphocytosis, so as to compensate the decrease in the granulocyte. That's what it's called. If you have, in the case of an absolute granulopenia. Now, chronic lymphocytic leukemia. If you have a chronic lymphocytic leukemia, that's a case where you are going to have a reactive, which always accompanied by absolute relative lymphocytosis. But like things like chronic lymphocytic leukemia are not actually involved with reactive lymphocytosis, but they are mostly involved with pathologies of lymphocytes. Now, in cases where the lymphocytes now are transformed, so these cases are when the lymphocytes are morphologically normal. Now, the lymphocyte, in this case, you have lymphocytes which are transformed and they are abnormal in size. The first one, you have lymphomatous toxoplasmosis. Is it clear? So you have a toxoplasmosis that causes a change in the lymphocyte shape and they are increasing number. The second one, you have rubella infection. Rubella infection causes a change in morphology of the white blood cells and an increase in number. You have hepatitis, and you have most lymphocytic transformation in the case of Epstein-Barr virus, which causes Burkitt's lymphoma. So all that is involved with reactive lymphocytosis. Now, in this case, in this diagram, you're going to see lymphatic reactive state. Is it clear? So diagram A to E show a wide variability in the lymphatic cells. Is it clear? A lymphocytic infection. So in this case, you have a cytomegalovirus infection. So some cells may resemble myelocytes. You see some cells here are very big and resemble myelocytes. Some cells here are very small. So you have a very different series of myelocytes or lymphocytes when you are having infections. You have different series of lymphocytes when you are having an acute infection. Like in this case, it's a chronic, it's a cytomegalovirus infection. Now, this is just to explain that when you have an acute infection, there are certain cells, different cells that are going to be produced. Like these cells are immature cells. These other cells are going to be memory cells. These other cells are going to be plasma cells that are produced. So we have the peculiar characteristic is that plasma cells is going to have an o'clock appearance inside the nucleus. Is it clear? So all these are going to be involved now in order to clear off the disease. Now, what are the characteristics of infectious mononucleosis? Is it clear? So, infectious mononucleosis is also another example of an excessive increase in number of lymphocytes. Infectious mononucleosis. Is it clear? Now, you need to know that so you need to know the character, and that infectious mononucleosis is just like a Burkitt's lymphoma. Burkitt's lymphoma is actually a lymphoma because it affects all the lymph nodes, but infectious mononucleosis do not affect lymph nodes. It only causes an excess number of white blood cells of lymphocytes. Is this clear? When it causes an excess number of lymphocytes, it's due to an Epstein-Barr virus. Is it clear? So this is a form of a reactive lymphocytosis which is due to Epstein-Barr virus and involve a morphological change in the white blood cells. So what are the characteristics of the age? The different characteristics of infectious monocytosis. The age of onset is usually children, school age. Now, clinical finding, you have enlarged lymph nodes, you have inflammation of the throat and possibly the spleen. You have the complete leukocyte, you have increase in the number of leukocytes. You have stimulated lymph nodes, you have partially lymphoblasts inside the blood. You may see some lymphoblasts inside the blood. But the more you see lymphoblasts inside the blood, the more you think of a leukemia than a lymphoma or other disease, because the lymphoblasts are involved in the bone marrow. Further diagnosis, you need to know that you should think of Epstein-Barr virus under. You have serological tests like immunoglobulins involve the Epstein-Barr virus, and you also have transaminase usually increase because also affect sometimes the liver. The differential diagnosis now for infectious mononucleosis, you can think of lymphomas, because infectious mononucleosis is not actually lymphoma. What differentiates is that a lymphoma is going to cause an enlarged lymph node and an abnormality in the histology of a lymph node. Those ones are going to be lymphomas. But in case of infectious mononucleosis, it's just going to result to enlarged lymph node, but the architecture of the lymph nodes is going to be the same as a normal lymph node histology. Now, it can make you also think of a leukemia. Why? Because there are also lymphoblasts at the level of the blood. Is it clear? Because leukemias involve an increased production of the white blood cells from the bone marrow. Since there is increased production of white blood cells from the bone marrow, there is going to be increased level of the blast cells, the precursors of the lymphocytes, which are the lymphoblasts. So since there is also that lymphoblast in blood, it may make you think of a leukemia, while it is not. You have persistent disease. If you have persistent disease, you have possibly tests of the cell markers also involved here. Now, the cause, how do you treat? The treatment is done for 2 to 4 weeks with palliative. So actually the patient is going to regress the disease by himself. So it's only done 2 to 4 weeks treatment with palliative care. So that is for the first case. So you need to visualize now how do you see infectious mononucleosis on microscopy. So lymphocytes during the viral infection. So you need to know that during the viral infection you can see blast cells. These are actually blast cells. You see, they are very large, with their nucleus which is very large, and that nucleus is also having a greater part of euchromatin. Is it clear? So these are blast nucleus forms. So here they are also called the Pfeiffer cells. These large nucleus are also called the Pfeiffer cells, and these big cells like that are due to the infection with the Epstein-Barr virus. Is it clear? So they are looking like blast cells. They are not actually blast cells. So they are only there are cells, the normal cells which have changed morphology because of Epstein-Barr virus. They look like blast cells on microscopy. I mean, it may make you think that there are increased number of lymphoblasts. Why there is not? Is it clear? So that is diagram A. So diagram B, so these cells are increased. They are called FAFA cells. Diagram B, we have virocytes with homogeneous deep blue stained cytoplasm caused due to Epstein-Barr virus. So these are still the other cells which resemble like blast cells that are infected with Epstein-Barr virus. They are called virocytes. So in addition, so in the next one, diagram C, the virus infection can lead to elevated count of the granulated lymphocyte. Is it clear? You can have an increased number of granulated lymphocyte Epstein-Barr virus in diagram C. And then in diagram and the monocytes, like in this case the monocytes, this is an example of a monocyte. It may also increase in number in infectious mononucleosis. When we say infective mononucleosis, it just means that what? It just means that the number of cells with one nucleus are going to increase. It's both lymphocyte and the monocyte. Like in this case, you have a bell-shaped nucleus like that, which is typical for the macrophages or the monocyte, and the monocyte also increase in case of infective mononucleosis. Now in diagram D, we have a severe lymphatic stress reaction with increase with granulated lymphocyte. And you need to know that normally the lymphocytes are not granulated. Is it clear? Now in this case, infected mononucleosis, you see a big nucleus, one single nucleus like that, and then you see the inside the cell like that there is granulation tissue which is azurophilic or basophilic. Is it clear? So when you see a large like that, so we see granulated, you can think of granulated lymphocyte. A lymphoma must be considered when you have the finding persistent. And now, when you could consider lymphoma, what may make you to rule out the lymphoma is to go to do a biopsy of the lymph node. If it is normal architecture of the lymph node, there is infectious mononucleosis. Now, the next thing is disease of the lymphatic. So the disease of the lymphatic, we're going to speak about the lymphomas. We now consider lymphomas. You need to know that what generally the lymphomas is divided into two. We have Hodgkin lymphoma and we have non-Hodgkin lymphomas, and their difference is going to be based on microscopy. Where in Hodgkin lymphoma you are going to see Ritzenberg cells, and Ritzenberg cells are lymphocytes, or they are white blood cells that have an owl-eye appearance. Is it clear? They have an owl-eye appearance. Those are Ritzenberg cells. Now, the next thing I want to speak again is that the next difference between Hodgkin lymphoma and non-Hodgkin lymphoma is not actually, this difference is not actually clear-cut, but we can just think that what Hodgkin lymphoma primarily affect the lymph nodes. Is it clear? While non-Hodgkin lymphoma can affect the lymph node and can affect also other mucosal associated lymphatic tissues. They can affect other lymphatic tissues generally. Is it clear? The example, we have mucosal associated lymphatic tissue, you have bronchus associated lymphatic tissue, you have the spleen, and you have all the like. So that's why a patient has non-Hodgkin lymphoma may have disease in the GIT with the mucosal associated lymphatic tissue. He may have disease in the respiratory tract with the bronchus associated lymphatic tissue. He may have diseases. He may have disease in the spleen, enlarged spleen. He may also have disease in the liver because of also the lymphatic tissue in the liver. He may have disease in the skin because of the lymphatic tissue in the skin. So because of the lymphatic tissue in the skin, he has disease inside the upper respiratory tract, the tonsils, the pale patches, and all that, just because all this is involved with non-Hodgkin lymphoma. So that's another difference, but that difference is not clear-cut difference in textbooks. The major difference is the stem cell cells present inside Hodgkin lymphoma. So those are the different cases. Now we have classification. You have WHO you have the care classification, you have the clinical characteristics, and you have the markers. So for lymphomas, you need to know that what you have lymphoblastic lymphomas. Is it clear? The first WHO classification you have. So if you have a precursor lymphomas, these forms of lymphomas are more considered as leukemia than lymphomas. As I've told you, when the white blood cells are coming directly from the bone marrow, is it clear, there are more of leukemias than lymphomas. So this type of lymphoma classified under WHO, which is said to be a B lymphoblastic leukemia, the B lymphoblastic lymphoma, it can also be called a leukemia. You also have a precursor B cell active lymphoblastic leukemia. Is it clear? So these are the different markers which are involved. So with B lymphoblastic leukemia, we have the CDL, we have the C1922, and we have the C78 plus. Now, in the mature B cell lymphoma, the mature B cell lymphoma can be considered in the case of chronic lymphocytic leukemias. Is it clear? So in chronic lymphocytic leukemia, it contains the hyperplasmacytosis. So you have chronic lymphocytic leukemia, and in the care classification is still called B cells chronic lymphocytic leukemia. Is it clear? So that we also have a B cell polymorphocytic lymphomas. And now the next one, you still have the WHO classification. We have lymphoblastic leukemia, we have mantle cell lymphomas, we have marginal zone lymphomas, we have follicular lymphomas, we have hairy cell lymphomas, we have plasma cell myeloma. So all these are the different examples of lymphomas. So so let's see now the different things involved here. So we start with the chronic lymphocytic leukemia. Is it clear? So those are you have seen already all the different forms of lymphomas and the different characteristics. Is it clear? And those characteristics, when you want to characterize a good lymphoma, the best thing is to do a biopsy. So when you're going to do a biopsy, you're going to visualize the different characteristics, and also you can also do a immunochemistry. Immunochemistry is going to help you to identify the receptors which are located here, and the biopsy can help you to identify the architecture, which can help you to know which type of lymphoma it is going to be. Example: the follicular lymphoma is a form of a non-Hodgkin lymphoma that is going to be affecting the follicles of the lymph nodes. The mantle zone lymphoma is a form of a non-Hodgkin lymphoma that is going to affect the mantle zone of the lymph nodes. You have the plasma cell myeloma is also another form of non-Hodgkin lymphoma that is going to affect the plasma, the position of the plasma cells. Is it clear? So all these are the cells involved here. Is it clear? So these are the different cells involved in lymphomas. Now, in case of Hodgkin lymphoma, we have three main types of Hodgkin lymphoma that I'm giving you as an assignment for you to go and check. It's very easy to know the three main types. Why the other types like that, the mantle cells lymphoma, the follicular cell lymphoma, the plasma cells lymphoma, the marginal cells, the marginal zone lymphoma, and all that are mostly involved. You have diffuse large B cell lymphomas, you have Burkitt's lymphomas. All these are non-Hodgkin lymphomas. There are only three Hodgkin lymphomas that I'm giving you to go and do as an assignment. Now, so this at first we saw for the B cell lymphoma. This now is for the T cells lymphoma. So for T cell lymphoma, we have the T polymorphic leukemia, which is still as considered as a leukemia. You have a large granular cell leukemia, which is still considered as a leukemia. You have T cell lymphoblastic leukemia, still leukemia. Now for the lymphomas, we have this other one here. We have lymphoblastic T cell lymphomas. You have T cell lymphoma. You have Leonard lymphoma and all that. And these are the different clinical characteristics. Now, we continue with the chronic lymphocytic leukemia. So now we have left from lymphoma, we are now in leukemia. Now, when you hear the word lymphocytic leukemia, is it clear? because I want you to know now that leukemia, there are different forms of leukemia. Now, based on the hematopoietic system, based on the hematopoietic production of the lymphocytes, you need to know that what the lymphocyte can have a precursor, which generally called the lymphoblast. Is it clear? And then the lymphoblasts are going to produce the lymphocyte. So let's just have a brief view of how the lymphocytes are going to be produced and how they mature. So the lymphoblast is going to either differentiate to produce the T lymphocyte or the B lymphocyte. When the TB lymphocytes are produced, they are produced in the bone marrow, and they are become active. They are activated in the bone marrow. Is it clear? So it means that what? When the B lymphocytes are produced, they are called immature B lymphocyte. Is it clear? Now, when they are called immature or B lymphocyte or naive B lymphocyte, they are going to pass a test. Is it clear? So we have those lymphocytes. They are going to pass a test, and that test is that what? Macrophages are going to show them antigens. Is it clear? If the B lymphocytes now react with the self-antigen, if the B lymphocyte react with the self-antigen, they are going to be directly killed. Why? In case where they don't react with the self-antigen, they are going to pass this test, and then they become naive B cells. So the first you have immature B cells, which become naive B cells when they pass the test, and then later on, the naive B cells now are going to pass on to the different lymph nodes. Is it clear? They're going to pass on to the different follicles of the body. The follicles constituting of the germinal center and the outer cortex. Is it clear? Or marginal zone. So it's going to produce that. Now the next one is that's for the production of B lymphocyte. Now the production of T lymphocytes are what? You have the premature T cells are going to be produced. The premature T cells are going to be produced at the level of the bone marrow. Now the premature T cells go now at the level of the thymus, and that is the place where they are going to pass the test. In the thymus, they are going to be shown self-antigen. If they react with the self-antigen, they are going to be killed. But if they don't react with the self-antigen, they now become the naive T cells. And the naive T cells now have to move now to the different lymph nodes, the different diffuse lymphatic tissues, such that it can receive antigen to become specialized, like in the case of memory T cells, the T helper cells, the T other cells. So this is how you have the different generally the hematopoietic system for the lymphocyte. Now this is very important. This cycle is very important in order to name the different forms of leukemia. Now you need to know that what if you have a lymphoblastic leukemia, it means that what it can either be a B cell lymphoblastic leukemia affecting all the cells of the B cell, or it can be a T cell lymphoblastic leukemia. Is it clear? And when you have a lymphoblastic leukemia, it means that the number of lymphoblasts which are present in the bone marrow are the one having the pathology. So they are the one that are going to increase in number. And you need to know that what the lymphoblasts do not have enough of the different enzymes which are involved in the normal immunity of the cell. So the lymphoblasts are going to be big. You are going to have a large number of white blood cells, but the white blood cells are ineffective. The next one is you can have also a lymphocytic leukemia. A lymphocytic leukemia is when the lymphocyte has been produced, but they are still naive. Is it clear? So you can have a B lymphocytic leukemia when they are being produced completely and they are out of the bone marrow. And you can have also a T lymphocytic leukemia when they are produced completely and they are out of the thymus, but they are ineffective. So that's why those cases are called lymphocytic leukemias. Is it clear? So usually you need to know that what lymphoblastic leukemias are involving lymphoblasts which are produced directly in the bone marrow. So if you have an excess number of cells in the bone marrow, it's going to be seen very fast. The disease is going to be seen very fast. Is it clear? Because the lymphoblasts are going to support the other cells which are inside the bone marrow. So the patient is going to have anemia, the patient is going to have difficulty to coagulate blood because of thrombocytopenia, the patient is going to have severe infections. So all this is because of excessive lymphoblasts inside the bone marrow. So when you have lymphoblastic leukemia, it is going to be shown very fast. This is going to be shown very fast. That's why usually lymphoblastic leukemia are called acute lymphoblastic leukemias. Is it clear? Now, when in cases of lymphocytic leukemias, here the lymphocytes are out of the bone marrow. So when there is an increased proliferation of lymphocytes, they are not going to affect the bone marrow again. They are going to be inside the follicles, the diffuse lymphatic tissues. Is it clear? And now in those cases, when they grow at that level, they are going to metastasize in the bone marrow when the disease is late. That is why the disease presents late, and that is why the disease is called a chronic. Usually, lymphocytic leukemia are called chronic lymphocytic leukemias. Is it clear? Okay. Now the question you want to ask me is, why is that they are called leukemias and not lymphomas? They are called leukemias because they still come from the bone marrow. Is it clear? While lymphomas are already mature B or T cells producing pathologies in their lymphatic tissues. Is it clear? Now, the next one is this picture. So you have this picture. So these are the different pictures involved here in chronic lymphoblastic leukemia. So the diagram A shows an extensive proliferation of the lymphocytes with densely structured nuclei. So you see their nuclei is going to be densely structured. When you see densely structured nuclei, you may think of lymphoblasts. Is it clear? So the nuclear shadow is a sign of fragility of the cells. Now the next diagram is diagram C. So in diagram C, you have slightly eccentric enlarged cytoplasm with lymphoplasmacytoids. Is it clear? So diagram D, we have this is diagram D here. You have proliferation of atypical large lymphocytes. Is it clear? With irregularly structured nucleus. So here lymphocyte, and then diagram A, the bone marrow cytology. This is the bone marrow cytology where you see large number of lymphoblasts in the bone marrow cytology. Now, in the bone marrow cytology of lymphocytic leukemia, you're going to see large number of lymphocytes. But the difference is that in lymphoblastic leukemia, the lymphoblasts are difficult to move out of the bone marrow. They want to stay inside the bone marrow. Is it clear? In lymphoblastic leukemia, they want to stay inside the bone marrow. That's why the disease occurs early. While in lymphocytic leukemia, though they are producing the bone marrow, they want to move out of the bone marrow. Is it clear? Like the normal lymphocyte. That's why they occur late. Now, in chronic lymphocytic leukemia, we have different classifications involved. Is it clear? So we have the staging based on Rye, and you have the staging based on Binet. The staging based on Binet came later, while that of Rye came earlier. So you have the staging is divided into 0 to 4. 0 is considered as low risk, 1 and 2 is considered as intermediate risk, and then 3 and 4 are considered of high risk of chronic lymphoblastic leukemia. So low is 0 if the lymphocytosis is greater than 15,000 white blood cells per microliter. You have the bone marrow infiltration is greater than 40%. So the bone marrow infiltration is greater than 40%, considered as low risk. Now, 1 intermediate risk, lymphocytosis and lymphadenopathy. So if you have lymphocytosis, increased number of white blood cells, and you also have enlarged lymph nodes, which are called lymphadenopathy, you think of 1. 2 is the classification where you have lymphocytosis and you have hepatomegaly, where there is the now proliferation now inside the liver. hepatomegaly, large liver, and splenomegaly, large lymph node with or without lymphadenopathy. If you have already the involvement of that, so you may have plus lymphadenopathy plus the liver and the spleen involved. It's already 2. Now 3 is when what you have lymphocytosis and anemia. You see that one. Normally, when the lymphocytes are produced in the bone marrow, those lymphocytes, immature lymphocytes, they are going to be high in the bone marrow effectively. That's why it is the difference between the leukemia and the lymphoma. They are going to be high in the bone marrow. The lymphocytic cells in leukemia are produced from the bone marrow, while the lymphocytic cells from lymphoma are produced from the different lymphatic tissues. Since they are going to be normally when they are high in the bone marrow, they directly move to go to the different lymphatic tissue. The first lymphatic tissue they will move on to are the lymph nodes. Is it clear? The next lymphatic tissue they will move on to are the mucosa associated lymphatic tissue, diffuse lymphatic tissues, and the next lymphatic tissue they are going to move on to are the spleen and the liver. So at first, that's why at first in stage 0 you just have a lymphocytosis. Is it clear? You can have bone marrow infiltration because that's normally how they are supposed to present. You should have lymphocytosis and you should have a high number of lymphocytes inside the bone marrow, like greater than 40%. Now stage 1 now, if you have lymphocytosis and lymphadenopathy, because they are going to try to move the lymph node, is stage 1. Stage 2, if you have lymphocytosis now plus lymphadenopathy or without lymphadenopathy and plus hepatomegaly and splenomegaly, because after the lymph nodes they will move to the spleen and the liver. That's stage 2. Stage 3 is if you have lymphadenopathy, they have moved to the spleen, they have moved to the lymph nodes, they have moved to the liver. There is no place to go again. They are going to stay now in the bone marrow. So when they stay in the bone marrow, they are going to inhibit the other hematopoietic system and cause anemia, like a hemoglobin of less than 11 grams per deciliter with or without lymphadenopathy. Is it clear? And the next one is stage 4, when you have a thrombocytosis with thrombocytopenia. So when the anemia comes from the hemoglobin of less than 11, and then you have now a thrombocytopenia which comes with the less than thrombocyte count of less than 100,000 cells per microliter. Is it clear? With or without anemia. So when you have all this, or with or without lymphadenopathy, with or without organomegaly, so when you have all this, you think of a high stage 3 and 4, which is a high risk. So the next one, you also have the next one, which is the Binet classification. So for the Binet classification, I cannot really explain, but you just have A, B, and C. A, you have a hemoglobin level of greater than 10 grams per deciliter. With you have normal thrombocyte count. So less than 3 regions of the enlarged lymph nodes. So you touch enlarged lymph nodes, you can have axillary lymph nodes enlarged, one axillary lymph node enlarged, one iliac lymph node enlarged, and one cervical lymph nodes enlarged. So those are the 3 regions. Less than 3 regions of enlarged lymph nodes, you have a hemoglobin of greater than 10 grams per deciliter. I have normal platelet count. The next one is B. If you have still hemoglobin of greater than 10 grams per deciliter, you have greater than 3 regions of enlarged lymph nodes, and you still have normal thrombocyte. The thrombocyte count and the hemoglobin start to decrease when you have a C, high risk. So this can be considered low risk, intermediate risk, and high risk. As easy as that in Binet. So when the HB is 10.0 grams per deciliter and the thrombocyte count is less than 100,000 cells per microliter, and you also have different, so when they are already low, even if there is a lymphadenopathy or not, just know that there is a high risk of chronic lymphoblastic leukemia, lymphocytic leukemia, in Binet classification. So what are the characteristics of chronic lymphocytic leukemia? The age of onset is usually in adulthood, because it may occur since, but since it's chronic, you usually see that in adulthood. Clinical presentation, you have gradual enlargement of the lymph nodes, usually moderately enlarged spleen. You can also have onset of anemia. The onset of anemia and the thrombocytopenia and those diseases are the ones that are going to make now come the patient to the hospital. So it's when the bone marrow is now infiltrated excessively that the patient now comes to the hospital. Chronic, we have complete blood count. In cases of lymphocytosis, you can have in lymphocytosis, you have decreased hemoglobin, you have decreased monocytosis, and you can have decreased immunoglobulins. Why? Because the B cell activity are also going to reduce. Now, the further diagnosis, in order to do a further diagnosis to be complete here, you're going to do lymphocyte markers. You're going to visualize lymphocyte markers. You're going to see bone marrow aspiration to see the infiltration. You are going to see lymph node histology to clarify the diagnosis, because the lymph node histology, you see, when you are going to see the lymph node histology, you may have just enlarged lymph nodes, but you will not have malformed architecture like in cases of lymphomas. In lymphomas, you have enlarged lymph nodes and malformed architecture. The architecture of lymph nodes is changed. That's why we make you to call it a lymphoma. But in other diseases, the lymph nodes are going to be enlarged, but the architecture is going to remain the same. So that make you not to change your diagnosis. So the differential diagnosis again, you can think of lymphomas, you can think of acute leukemias, so other acute leukemias and other. Now the course of therapy individuals, so it's varying between individuals. Is it clear? And usually we use here chemotherapy. And based on the different classification, the grading of the disease, low risk disease, you have to high risk disease, you have a different prognosis. It's normal that the high risk is going to have the worst prognosis. Now, this is how they resemble now on microscopy. So on microscopy, you're going to have lymphoma of the B cells and the T cells lineage. Normally, when you have a lymphocytic leukemia, you cannot differentiate if it is from B cells or T cells. You cannot easily differentiate. So diagram A shows prevalence of large lymphocytes with clearly defined nucleoid. Large lymphocyte clearly defined nucleoid. So diagram B shows the presence of large blastic cells. So this is an example of a large blastic cell. But when you see large blastic cell, it is more of a lymphoblast. And then so normally in lymphocytic, the cells are going to be normal size and they are going to be immature. Is it clear? Because in that process, they are not going to shift from the step of, they are going to be premature cells. They are not going to pass that test that I've told you, the test from premature to naive cells. So to pass the test from premature to naive cell, you need to show your antigens first to the macrophages. In this case, they have not passed that test, so they are premature B cells or premature T cells. That's why you may see them as lymphoblasts, but they are not actually lymphoblasts. They are just premature, or they may even go and pass the test on macrophages, but they don't pass the test that naive cells have normally to pass to become activated cells. That is why there are going to be many naive cells in the circulation of many premature lymphocytes in circulations, and that is not going to be effective in working in any infections. So in this diagram, the next is diagram D. So diagram D is going to, the next one is diagram C. If you have a rare, this is a Sézary syndrome where you have a T cell lymphoma of the skin. Sézary syndrome, T cell lymphoma of the skin. The next one, sometimes lymphocytic leukemia can be considered as lymphoma, sometimes not. So that is in the case of Sézary syndrome, T cell lymphoma of the skin. The next is diagram T, which shows a pro-myelocytic leukemia. So my pro-myelocytic leukemia. And then the last one is diagram E. You have the bone marrow of the lymphoplasmacetic immunocytoma. So these are the bone marrow finding. Now, the next disorder you're going to see is lymphoplasmacetic lymphoma. So this is a form of a lymphoma. So what are the characteristics of lymphoplasmacetic lymphoma? So the lymphoplasmacetic lymphoma characteristic. We have lymphoplasmacytoid immunocytoma, and we also have lymphoplasmacetic lymphoma. Lymphoplasmacytoid immunocytoma, this is a special form of basal chronic lymphocytic lymphoma. So all these are actually chronic lymphocytic lymphomas, in which usually only one precursor migrates into the bloodstream. A diagnosis may only be possible on the basis of the bone marrow or the lymph node analysis. The next one is a lymphoplasmacetic lymphoma. A lymphoplasmacetic lymphoma, few precursors migrate into the bloodstream. Bone marrow or the lymph node analysis is sometimes necessary also, but here you need also immunoglobulin analysis. Now, the next thing, so after the lymphoplasmacetic lymphomas is which is still a chronic lymphoblastic leukemia, is now a case of a facultative leukemic lymphoma. So facultative leukemic lymphomas, which are actually lymphomas, we have mantle cell lymphoma, we have follicular cell lymphoma. Mantle cell lymphoma, follicular cell lymphoma are examples of non-Hodgkin lymphoma. So how do you visualize it? So mantle cell lymphoma, actually, how do you visualize mantle cell? So you have a dense diagram. A shows a dense chromatin. You can visualize dense chromatin here and a small indentation. You see dense chromatin, you see small indentation, dense chromatin, small indentation. Basically of the nuclei suggests the migration of leukemic mantle cell lymphomas into the bloodstream. Is it clear? So now these cells in the mantle cell lymphomas, you are going to see that what they have a dense nucleus, and they have one small indentation here. You think of mantle cell lymphomas, which has you think of mantle cells which are derived from the mantle zone. Is it clear? The next is this. So diagram B now is going to show a denser chromatin and a sharp indentation. In this case, you see sharp indentation because of migration from follicular lymphoma. So in this, you have a small indentation in mantle cell lymphoma, while in follicular cell lymphoma, you can see a very sharp indentation, like in case of a follicular cell lymphoma. Now, diagram C here is going to this is the next one. Diagram C is when you see at the level of the lymph node. Is it clear? So it is a diffuse infiltrate at the level of the bone marrow. So it's a diffuse infiltration of the bone marrow with polygonal, in some cases indented lymphatic cells of the mantle zone. So you are going to see these indented cells here inside the bone marrow, and you may also see the sharp indented cells here, which are at the level from the follicular lymphomas cell in the bone marrow. So you may think of infiltration from those lymphomas. Now, the next one are the lymphomas that usually causes splenomegaly. So these are other forms of non-Hodgkin lymphomas. We have hairy cell leukemia, we have splenic lymphoma, and with villous lymphocytic. So splenomegaly may develop in all non-Hodgkin lymphomas, but in hairy cell leukemias, the rare splenic lymphadenoma with villous lymphocytes and marginal zone lymphadenoma are seen. So this is a case. So diagram A is a case of a hairy cell lymphoma. Actually, you see the cells are like this, and the future is as if they have hairs. That's why they are called hairy cell lymphoma. Is it clear? So we have fraying cytoplasm, which just make you think of hairs. So diagram B here is also the same thing with hairy cell leukemia. You have cell here with different fraying cytoplasm. We have fraying cytoplasm like that, just like hairs. That's why they're called hairy cell leukemia. Now diagram C here is also the same thing, but now this is going to be occurring now on a monocyte. So this way on lymphocyte, but this now is on monocyte. Monocyte because it has a bean-shaped cytoplasm. So this is now on the monocyte. And now the next one now is diagram D and E. Diagram D and E is when so diagram D and E is when the cytoplasmic processes look thicker. So you have the cytoplasm now is thicker and much less hairs are going to be found at the level. The diagnosis of the rare splenic lymphoma with villous lymphocyte must be considered when you have this. So when you have a lymphocyte which has a very large cytoplasm, is it clear? And you still have hairs, but the hairs are decreased. You have to think of the rare splenic lymphoma with villous lymphocyte. SLVM. Now the next cancer that we're going to see now are going to be cancer involving the plasma cells. Is it clear? Now before we saw one cancer which was a lymphoplasmacytoid lymphoma. That lymphoplasmacytoid lymphoma that lymphoplasmacytoid leukemia is not actually a plasma cell tumor. Why? Because those plasma cells that were produced there were from naive B cells. Is it clear? They were from naive B cells that have pathologies. Is it clear? But here in plasma cell tumor, the plasma cells are the one causing the tumor. It's not the naive B cells which are causing the tumors. Is it clear? Such that they are transformed into plasma cells. Is it clear? It is in this case, in plasma cell tumors, it is actually the plasma cells which are producing the disease. It's not the B cell, the precursor producing the disease. So, example of this plasma cell tumor, you can have a monoclonal gammopathy. So, when we say monoclonal gammopathy, what do we mean by that? It means that it's a plasma cell tumor where there is only one antibody that is going to be produced. That's why it's called monoclonal gammopathy. So, example of cases where you have monoclonal gammopathy, we have the first one, multiple myeloma. Second one, we have plasma cell myeloma. The third one is plasmacytoma. So now, what is differential diagnosis of monoclonal hypergammopathy? So you have the type. It can be benign disorder or it can be malignant disorder. For benign disorder, where you have monoclonal hypergammaglobulinemia, you have essential hypergammaglobulinemia occurring. So it's a monoclonal gammopathy of unknown significance. That's the first thing. Benign disorder where you have a high level of monoclonal, where you have a high monoclonal gammopathy. You can have a monoclonal gammopathy of unknown significance. Is it clear? That's essential hypergammaglobulinemia. So the characteristic is that you have the less usually advanced A, and you have the percentage of plasma cells are found to be low. That's less than 10% inside the bone marrow. The next one, we have symptomatic hypergammaglobulinemia. So you can have excess level of hypergammaglobulinemia, which is also produced in case of infection, because we react to infection, in case of a tumor, or in case of autoimmune disease. You can have malignant now disease. So malignant disease you can have in the case of plasmacytoma. In plasmacytoma, usually the immunoglobulin G, A, or light chains as benjoin proteins are produced. Rarely you have immunoglobulins M, D, and E which are produced. Is it clear? So that is for plasmacytoma. And now the next one is lymphoma. Lymphoma, you have immunocytoma, chronic lymphocytic leukemia. We see that you just remember that there was a case that there was a chronic lymphocytic leukemia which was a B cell leukemia. That's lymphoplasmacetic lymphoma. Is it clear? That lymphoplasmacetic lymphoma is produced from a naive B cell, and that naive B cell still produces the plasma cell, but it is not considered as an actual plasma cell tumor. Why? Because it's not produced directly from the plasma cell, but it's instead produced from its precursor, which is the naive B cell. Is it clear? So those are the different things involved here. So this diagram now is going to show you a reactive plasmacytosis and plasmacytoma. Is it clear? So A, you have the bone marrow cytology with clear reactive features. So here you have, this is at the plasma cell. The plasma cell, you can visualize actually the o'clock appearance here. You can visualize the o'clock appearance here, and you visualize the large vacuole. Is it clear? So these are the typical feature of a plasma cell. that is how it's going to resemble. You have a oblong appearance on the nucleus. I have a large whitish vacuole. Basically, that is the typical appearance of a plasma cell. Now, in diagram 1 here, you can visualize myelocyte. Diagram 2, you can visualize diagram 2. You can visualize other myelocytes. So diagram 1 is promyelocyte. Here is myelocyte. Basically, so in B, you can see extensive infiltration of the bone marrow of well-differentiated plasma cells. You can see well-differentiated plasma cells extensively proliferate inside the bone marrow. Normally, plasma cells should not be found inside the bone marrow because the plasma cells are located at the level of the lymphatic tissues, like the follicles or the diffuse lymphatic tissues. Is it clear? Normally, they're not supposed to be present in the bone marrow. When they are present in the bone marrow, just know there's an infiltrated disease from a plasma cell tumor. Is it clear? So that is it. Now the next thing is variability of plasmacytoma for morphology. So so these are the different variables. So to see that variability, we have the staging of plasmacytoma. Is it clear? So the staging of plasmacytoma, it can be staged into two. You have stage 1 and stage 2. Stage 3, it can be staged into 3, stage 1, stage 2, and stage 3 plasma cell tumor. So stage 1, you have all the following are present. You have a hemoglobin. The hemoglobin level is going to be greater than 10 grams per deciliter. Just means that what? It means that it has not yet infiltrated the bone marrow. It's at the beginning, starting at the level of the lymphatic tissues. The second, we have serum calcium is normal, because you need to know that what? You need to know that when there is excess level of the plasma cells can easily infiltrate inside the bones. Is it clear? To cause the dissolvation of the bones. That's why there is a mnemonics for multiple myeloma. So when you want to count multiple myeloma, you should know a mnemonics in mind. That mnemonics is called CRAB. C-R-A-B. Is it clear? That mnemonics is called CRAB. C-R-A-B. C for hypercalcemia. Why in multiple myeloma, which is a plasma cells tumor, they lie infiltrating the bone. That's one. Hypercalcemia for C. R is for renal abnormality or renal failure. Renal failure is because what? Is because this plasma cell tumor produces light chain immunoglobulins, which are going to be filtrated through the renal membranes or the glomerulus. So when they are filtrated through the glomerulus, they are destroying the glomerulus. Let's think that normally a door is supposed to, you have to think it as such. Normally, if a door is supposed to pass, let's say that one bottles are supposed to pass at the level of doors, but now you have a fridge that passes at the level of the law. We have many fridge that pass at the level of that door. You see that the door is going to open more. Is it clear? When that door is going to open more, it makes now a disorder with the functionality of that door. It's the same thing with the glomerulus. Since the immunoglobulins are also, the light chain protein are also passing through that same glomerulus with the normal particles, you see that there's going to be an abnormality. That's why you have renal failure. A is for anemia. Anemia is when the multiple myeloma is infiltrated now in the bone marrow. And then the last one is B, which is bone abnormality. So that's why it still coincides with the hypercalcemia. With the bone abnormality here, we have what? On the X-ray, I'm going to visualize that there is there is low sensitivity of bones. Is it clear? Demineralization of bones. So that's why here you have no anemia at the beginning in stage 1. You have serum calcium also is normal. You have the X-ray. You see all these characteristics are the characteristics in the CRAB. B again for X-ray. This normal bone structure. Now the next thing you can also see, they talk about the renal function. The renal function is normal. The urea and creatinine are normal. And then here we have immunoglobulins and immunoglobulin G and immunoglobulin A. And immunoglobulin G is less than 5 grams per deciliter. A is less than 3 grams per deciliter. And then there are light chains inside the urine. Is it clear? So the light chain inside urine is going to make the diagnosis of plasma cell tumor. When you see the light change inside your eye, it's not normal. You're going to see it makes you think of a diagnosis of plasma cell tumor. And also when you see infiltration in the bone marrow, it's not normal. It's what makes you think of a diagnosis of plasma cell lymphoma. Now in stage 2, we are finding people fulfill neither stage 1 nor stage 3. So when it is neither in stage 1 or stage 3, it is stage 2. And then the next one is stage 3 now. You have one or more of the following. If the hemoglobin now is less than 8.5 grams per deciliter, you think of a severe stage 3 plasma cell tumor. If the calcium level is elevated, if X-ray in the bone show bone lesion, if the hemoglobin is greater than 7 grams per deciliter, the hemoglobin A is greater than 5 grams per deciliter, the light chain is greater than 12 grams in 24 hours, just know that it is a stage 3 plasma cell tumor. Now, these are atypical cells in multiple myeloma. So, the first in A, we have extensive infiltration in the bone marrow of the plasma cells. You see, these are plasma cells. So, extensive infiltration of the bone marrow by loosely structured, slightly differentiated plasma cells with a white cytoplasm. Now, B is a multiple myeloma here with vacuolated cytoplasmic protein, so protein precipitate. So you see here, this one, they form they are differentiated. Normally the plasma cells are not supposed to resemble like this, but in this case you see the plasma cells have many vacuoles in the cytoplasm like that, many vacuoles in the cytoplasm, and the histochemistry show that it is actually a plasma cell. So just that make you think also of a plasma cell tumor, and in this case it's going to be multiple myeloma. So that's in diagram B. So in diagram C now, you have this. So in this case you have 2 nuclei. Is it clear? In the diagram C, it's a binucleated plasma cell and are frequently observed in still multiple myeloma. And then diagram D, you have differential diagnosis. We have red blood cells, red cells precursor. You can think of red cell precursors here, can sometimes look like plasma cells. So when you have red blood cell precursors can also look like plasma cells, is what is seen here in case of poor erythroblast increase in number. Now, the next disease is going to be a relative lymphocytosis due to a granulocytopenia. Is it clear? So, the relative lymphocytosis, this is when the lymphocyte number is going to increase because of a low level of granulocytes. So, a low level of granulocyte usually is because of neutropenia. Is it clear? So, that is called agranulocytosis. You still call it agranulocytosis. So what is classification of neutropenia and granulocytosis? What are the causes that makes neutropenia and granulocytosis? Actually, they are the same thing. Is it clear? Neutropenia is the decreased level of the neutrophils, while agranulocytosis is a relative increase in level of agranulocytes because of a low level of granulocytes, in bracket neutrophil, because neutrophil is the highest population of granulocytes. Now, the classification is that what you can have a drug-induced agranulocytosis in case where you have dose independent, so it consists of a dose independent acute granulocytosis. It consists of a relative dose dependent. So dose independent, it means that what, even if you increase the dose, you decrease the dose, you're going to have granulocytosis. Example of the drugs that causes it: you have antibiotics, you have thyrostatic drugs, you have anti-inflammatory drugs, you have this, and you can also have chemotherapeutic drugs. We have now relative drugs with relative, which is dependent to the dose. We have now antidepressant and all that, carbamazepine. We have drug dependent dose and all that, so immunosuppressant. Now, the next one is infection. So infection induced. So infection induced that may cause reactive lymphocytosis. You have one, Epstein-Barr virus, you have hepatitis, you have typhus, you have brucella, so it can cause an granulocytosis. The next one, you have autoimmune infections. Autoimmune diseases can be involved like systemic lupus erythematosus, you have pneumocystic jirovecii, you have Felty syndrome. So those are the different cases. You have also congenital and familial neutropenia. Is it clear? So in this case, it is going to be neutropenia, which is due to family, which is because of your congenital reason or familial reason. And the next one, you have secondary neutropenia in the bone marrow disease, because you have neutropenia because of a bone marrow disease, like in the case of a myelodysplastic syndrome. E.g., in case of acute leukemia, a plasmacytoma or pernicious anemia, anything that can result in a decreased level of the neutrophils. So this is a diagram. So the bone marrow in agranulocytosis. So when you have bone marrow agranulocytosis, so in early phase of the agranulocyte, the bone marrow show the red cell precursors. So you have the red cell precursors here. So you can see also the plasma cells and all that. So here you see the bone marrow in this case here in agranulocytosis during promyelocytic plasma phase, showing almost exclusively the promyelocytes. Is it clear? So you don't see again all those precursors. And the last thing under the relative increase of round to over cell, that is agranulocyte increase, you have monocytosis. So monocytosis is the increased level of the macrophages, the monocyte. Is it clear? This monocytosis, you have possible cause of monocytosis. It can be infectious, it can be chronic reactive condition, it can be a paraneoplasm, or it can be a neoplasm. Infection, you have mononucleosis, like in case of Epstein-Barr virus. You have listeriosis, you have acute viral hepatitis, you have parotitis epidemidica, you have chickenpox, you have recurrent fever, you have syphilis, you have tuberculosis, you have endocarditis, and you can continue the list. Now, chronic reactive condition. In chronic reactive condition, that makes an increased level of monocytosis in a chronic case. You can have autoimmune disorder, a chronic dermatosis, a regional ileitis, and sarcoidosis. Now, a paraneoplasm, it resembles like a neoplasm. You have the first one is large solid tumor, and the next one is lymphogranulomatosis, and the last disease now is neoplasm. So in case of neoplasm, you can have a chronic myelomonocytic leukemia. Basically, it's a myeloma. We need to know that one. Sometimes things, so theories say that the monocytes are produced from the lymphoblast. Some theories say that the monocytes are produced from the myeloblast. But generally, you have to think that the monocytes are produced from the myeloblast. Basically, so that's why I say chronic myelomonocytic leukemias. This textbook. Some textbook may say chronic lymphomonocytic leukemias. The next one is acute monocytic leukemia. Is another disease, and we also have acute myelomonocytic leukemia. Those are the different leukemia that you can have here. Now, in monocyte disease, so when you have reactive monocytosis and monocytic leukemia, so in reactive and neoplastic monocytic disease, normally the monocyte see that it has an indentation, is it clear, and it's very large in size. As you can see here in diagram B, whenever monocytes are found exclusively, a malignant etiology is likely. So when you have a large level of monocyte, just think of a malignant etiology. So the next one here is diagram C, where you can see monocytes here with malformed nucleus here. So this nucleus here is malformed, and also in diagram E, where there is diagram C, where the nucleus here malformed. This is the same diagram. Now the next disease are acute leukemias. Is it clear? So acute leukemias, you have type of acute. So we have type of leukemias. The type of leukemia, as I've just said in the introduction, is that you have acute leukemias. So we have chronic myeloid. So we have acute leukemias. Acute leukemia can either be from a myeloid origin, or it can be from a lymphoid origin. Is it clear? So it can be an acute myeloid leukemia, or it can be an acute lymphoid leukemia. Is it clear? So these are always acute diseases. when they are going to result to anemia, result to hemorrhage because of a decrease in functionality of the bone marrow, other bone marrow cells. Now we have chronic myeloid leukemia. So in chronic myeloid leukemia, now you have what? You have persistent leukemic disease. Is it clear? So we say persistent leukemic disease, like chronic myeloid leukemia coming from the myeloid pathway is going to be persistent. Now the chronic myeloid leukemia is more of a leukemia than a lymphoma, while chronic lymphocytic leukemia is more of a lymphoma than a leukemia. Why? In case of chronic myeloid leukemia, you need to know that what the normal, I've said already, we have already seen the introduction how the myeloblastic series goes on. In the myeloblastic series, you start with the myeloblast, then you go to the myelocyte, then you go to the active cells, which are the neutrophils, xenophils, and the basophils. Is it clear? Now you need to know that what in the case of a myeloblastic leukemia, usually the myeloblastic leukemia is going to be acute. Is it clear? Myeloblastic leukemia is acute because the myeloblasts, just like the lymphoblast in acute lymphoblastic leukemia, the myeloblasts are going to stay in the bone marrow and suppress other bone marrow tissues. So that the patient is going to have anemia because the red blood cell is suppressed. The patient is going to have thrombocyte hemorrhage because the thrombocyte level is going to be suppressed. Is it clear? Now that is for myeloblastic leukemias. Now for myelocytic leukemias, is it clear? Like in this case, it's called chronic myeloid leukemia. Here in the bone marrow, you have myelocytes such as the neutrophils, you have eosinophils, and you have basophils. Is it clear? You see actually myelocytes, or you see the cells which are at the last phase. Is it clear? But now the problem is that unlike the case of lymphocytic leukemia, when they are produced in the bone marrow, they directly go to the lymphatic tissue. In myelocytic leukemia, when they are produced in the bone marrow, they like staying in the bone marrow. The myelocytes like staying in the bone marrow. That's why they are more called a leukemia than a lymphoma. Is it clear? So you have chronic myelocytic leukemia. As you can see, though it's a chronic disease, and if it migrates, it will migrate to the spleen. That's why it results to a splenomegaly. So you have a chronic lymphocytic leukemia that we have already defined. It can be of B cell etiology in 90% of cases, or it can be T cell etiology in other percent of cases. We have polymorphocytic leukemia, we have hairy cell leukemia. So those are the different things. The next one is chronic myelomonocytic leukemia. Is another form which is due to a monocyte. Is it clear? So we have leukemic form of the myelodysplasia, classified between myelodysplasia and myeloproliferative disease. So it's a subacute disease in the transition acute form of myeloid leukemia. So these are the different things that we have visualized under the white blood cell series. So you say thanks for your kind attention. Please don't forget to like and subscribe for Science Video Makers. Thank you.